know what she said, she might just change your life.
And we're back in studio, and we are joined now by Mary Jane Dykeman. Welcome to What She Said.
Thank you.
Now, you are a partner at DDO Health Law in Toronto and co-creator of the Huddle Series. Now, let's dive right in. Tell us what the Huddle Series is.
We're really excited about this. We've been health lawyers, Kathy O'Brien, Kate Dewhurst, and myself for up to 20 years each. And we've been serving hospitals, long-term care homes, community mental health and addictions, so the organizations that provide the health care. Mm-hmm. We thought this would be a great way to take some of the training that we do and some of the learning from years past and actually move it out into the public as well. So we've been shooting videos since last June, and that is all new for lawyers. We don't do what you do all day, every day, frankly. So it's a bit daunting on the one hand, but we just jumped in and did it. And so we've captured a couple of different video series, one for Ontario healthcare organizations, for employers who have employees going through the health system. And then also we're making it available to the public as well, because we want to make sure that people have access.
What questions do you think the public need answered?
I think it's difficult enough to be a patient or a client or a resident in the healthcare system, so we're not clinicians, but it's still fairly complex. Lots of questions about the various laws, how do they apply, who is the substitute decision maker if I become incapable and I can't make my own decision. There is more time in my practice spent assisting some of those healthcare organizations when there's a tough patient or family situation. So that person may want a voice, but things are starting to break down a little bit in the communication.
So does that happen a lot with an aging population where people, family members start fighting over who's going to make the decision and you get called in?
Yes, we do a lot. It can happen in any circumstance. It may be parents of a child who start to disagree, but you've hit the nail on the head. It's the adult children of elderly parents, or there may be a spouse involved. And I think, generally speaking, people are very earnest. They want to do the right thing. They want to do well by their mother or father or spouse. But sometimes there's not a lot of control over the clinical side. So what we're trying to do is calm the waters a little bit, make sure that everyone has the same ground rules, whether it's the healthcare provider who's thrown into it, or it is the family member, to make sure that they have, again, the basics to start to navigate the system, not the clinical piece, because we'll leave that to our friends and colleagues delivering the care.
So then you take these videos, a series of videos, which incidentally you can find on thehuddleseries.com. Basically, and the tagline is simplifying the health system, right? That kind of says everything that you're trying to do. But the way you're doing it is you tell different people's stories. Like, tell us about Ruby's journey.
Right, so Ruby is one full video of about an hour, and it's my favorite because this is my passion. What will we do with fictitious Ruby? So we characterized her as an elderly woman living in her home still, very proud, very independent. I think we gave her a diagnosis of Alzheimer's and an age of, I don't know, 70s or 80s. And again, think of the population bulge that's coming. Everybody is Ruby, as far as we can tell. So she wants to stay in her home. Her health is starting to decline. People are allowed to make poor choices. If you're capable, you or I could make a bad choice any given day, and people might judge us, but that's our right. So neighbors are starting to get a bit worried. Maybe newspapers are piling up. The grounds are unkempt. Maybe police are called by times. We sometimes have people who wander, and this is not wandering out in the elements the way my children might in their early teenage years, rolling up their sleeves in the dead of winter. This is someone who is potentially at risk of serious physical impairment, which is one of the legal standards. And so ultimately we follow Ruby from her home, saying here's what she wants to do. Her husband died some time ago. Off she goes to emerge. And this is one of the things that we do see working in hospitals, that there may be a long lineup of stretchers in emerge of people who are starting to experience failure to thrive. And it just may be dehydration or a need to stabilize medications. But again, there's a bit of a cyclical pattern. How many times might she go to emerge and ultimately get stabilized and be sent home? And in our world, in the healthcare organizations, of course, staff are trying to navigate around Ruby and offer her the right services and not immediately say, well, you need to go off to long-term care, you can't live alone. Everyone would like to age at home. It's a question of how do you get those resources in? Do you purchase them? Do you have the Community Care Access Center or other public source and resource doing this? And so we follow her there. Ultimately, she's admitted to hospital, in this case, in Ontario law at least, but this could be anywhere. She's designated what we call alternate level of care. She stays in hospital. The CCAC, Community Care Access Center, steps in to assist her to choose up to 5 long-term care homes. By this time, we've characterized it that her adult children are now starting to bicker a little bit. They don't want anything to be done under the Mental Health Act. That's another piece in the toolkit. It's a bit of a, not the most nimble tool, but we're fairly limited sometimes, especially if she's saying, oh no, I don't want to be treated, I want to stay in my home. People don't always say out loud, I'm able to assume risk. They say it in different ways, but we also have set up that in this case, 2 adult daughters are starting to tangle a little bit. And I often say when I'm helping hospitals and long-term care homes, we want to enable and empower those family members because this is a situation over which there is very little control. But how do you find out what the system is, what the steps are, and where do you go for that one resource? So we follow her. She's admitted to long-term care in this case. We go through some of those issues, including all of the different legal tests for capacity because they're all different. They're assessed by different people. And then ultimately we take her straight through to end of life. And of course in Canada right now there's some developments on that front as well.
We'll talk about that.
Well, Mary Jane, I'm surprised because I didn't even actually know that there were a segment of lawyers who actually deal with this. And this, you're right, this is just just the beginning of an iceberg. And of course, let's throw some flames on that fire, and that is now talking about assisted dying.
Yes.
And
so
the what will happen in families where a parent wants to die and the children don't want that to happen, let's say, or a spouse.
I think we can assume that will be the case. We see it even now in decisions made by a capable person to withhold or withdraw treatment. This is obviously one step further and a very active step for someone, but this is the reality. As of June 6th, with the extension that the Supreme Court granted, now we're in a position that those prohibitions in the criminal code are going to fall away, and it is going to be available, and we're waiting to see what rules and parameters will apply.
Okay, well let's talk about that because a lot of people I know who are great proponents of this are now backing off, saying we think it's gone too far. How do you feel that the law helps and protects patients that do want to end their life, or do you think it is the slippery slope?
Well, we talk a lot about the slippery slope, and we've been talking about it since the Rodriguez decision, and that's 22 years ago. That was
that long ago.
Exactly, September of 1993. Wow. That was my first term in law school at Osgood, and so that was the start, and 22 years later, here we are, knowing that it will be available, much less how do we operationalize that, what will the rules be. So we're waiting to see what might the federal government do, the provincial government, the medical associations. Everyone is very watchful. It is in every discussion right now, and I'm fascinated because the Supreme Court of Canada, in landing on Carter, did not limit it to a person who is terminally ill. So there is the first step. The Joint Committee recommendations have suggested that it could go even broader. So they have invoked 3 somewhat controversial areas, being those with mental illness, and my colleagues in psychiatry who agree with the courts in terms of having assisted dying have also taken a bit of a step back. Well, how do we reconcile that with a recovery model? And recognizing that we may have to make some decisions on that front. And how would we assist when we think there may be effective treatments available to someone who is experiencing...
And minors may also be allowed to make this decision.
Now there's a moratorium or interim period, but that would put Canada way, I don't want to say ahead, it would put Canada further
in the forefront,
in the spectrum of possible options. So if you combine those two, think of someone who is 17 years old and under the Healthcare Consent Act in Ontario able to make decisions to withhold or withdraw. When you couple those two things together, a person who is not terminally ill, who is experiencing serious and irremediable suffering by their own account, this is their experience, with a mental illness, the youth psychiatrists also have raised questions, all right, what exactly does that mean? What will the protections be? And it's fairly polarized. So,
or if you take one of those young children that died recently because they didn't receive what I will use air quotes here and say, standardized hospitalization, medical treatment, chemotherapy,
exactly,
and stayed alive. She was, I believe, the last little girl was 9 or 11 years old. She could have theoretically, under this new set, said, I don't want to accept that. I'm not giving consent to that treatment, but I do know my life is going to end, so I would like you to help me end it now. At 11, she might have that.
So
right.
The healthcare consent rules do not apply age or diagnosis. So you could be a child who's able to meet the test.
So theoretically, a child, let's say an adolescent, who is suffering severe clinical depression, could, in that state of mind, when they are at their lowest point, make that decision and have the right to make that decision?
Right, and there will be protections built in, there will be reviews and clinical backup to it. But again, it's that challenge of how do we ensure that there is the appropriate review. And this is not to say, I think the spectrum has shifted since 1993 in Rodriguez. Society has said they are ready, but these are the issues to unpack and fairly quickly. So we will have guidance. We don't know yet. The third group, of course, is anyone who does it by way of a wish. If I say today, if and when I have a diagnosis of X and I experience Y, I would like it to be available to me at that time. So a future, again, a wish circumstance, a person with Alzheimer's or other type of dementia. Again, there's nothing to say that this is exactly where the rules will land, but this has been raised and it's part of the discussion. And Dr. Carrie Bowman, who's an ethicist at the University of Toronto Joint Centre for Bioethics and at Mount Sinai Hospital, part of Sinai Health System, and I have been out talking about the Carter case, and one of the things he's been saying to me for 20 years, and I quote him all the time, is the line in the sand shifts. So I could make a wish today, and I'm able to make my own wish while capable. Nobody else can come in and make a wish for me, even my substitute decision maker down the road. They're there to interpret my wish and give consent or not. But he has always said, you may find as things go that you are better able to deal with what you have. And again, not to say that we want to step away from what Carter stands for. It is live, it is real. We need to know what the rules will be, and I can tell you that the hospitals and long-term care homes I work with are very busy behind the scenes preparing, having the discussions, because even once the rules are in place, we know already if someone raises it, what is the, not to make it as cold as a decision tree, but how do we engage in that conversation? Do we get to the bottom of why it is? What are the parameters? How do we get down really into the details?
Click the channel subscribe button for full-length interviews and more from What She Said here on YouTube.